Welcome to Value-Based Voices, a podcast from the Association for Value-Based Cancer Care. Each episode dives into the shifting terrain of cancer care in the United States, exploring what value means in today's clinical, policy, and patient-centered environments. Our mission is to spark informed dialogue, promote transparency, and equip every stakeholder, from providers to payers to patients, with the insight they need to navigate cancer care with clarity, confidence, and purpose. My name is Jayson Slotnik, a partner at Health Policy Strategies and an AVBCC board member, and I'll be your host for this episode. It is my honor to have Brian Reid, principal of Reid Strategic, with me today, and we'll be covering a range of topics, from most favored nation to PBMs and beyond. We've got a lot to cover, so let's get to it. Welcome, Brian, and thank you for joining us.
I'm thrilled to be here.
Well, as I said, let's get into it. The topic du jour here in the swamp, as it always has been since the beginning of the new year, is most favored nation, the globe, the guard, the generous. You author a very successful blog. I don't know anybody else who has their pulse on Washington the way you do. So give us an open introduction about what you do and how you have your finger on that pulse. And what are your thoughts about the globe and the guard and the generous and where this is going and what to expect?
That sounds great. Thanks for having me. As you noted, I write a newsletter called Cost Curve, and the goal here is to kind of get everyone on the same page. There's so much going on in the commercial environment and the policy environment, and my goal is every morning to just kind of hoover that up and spit back, something that's going to help make sense of it. And obviously, spent a lot of time lately thinking about the broader universe of kind of MFN policies. How do we bring international reference pricing to the United States? That's obviously a priority of the administration. And so you mentioned, the regulatory piece of it. Can we do this? Can we bring international prices in via Medicare, Medicaid? And so CMS has come up with a number of models. I don't know how completely they've been thought through, but a lot of thought has gone into the naming of them. So we got the generous model, the globe model, and the guard model. So to take those in order, generous is the model that's designed to bring in international prices into Medicaid. We probably don't need to talk too much about that. Medicaid already gets pretty good prices. The generous formula is kind of baked into the MFN agreements that have been signed with 16 big pharma companies. I don't think anyone thinks that that's necessarily all that dramatic or interesting. The bigger deal, I think, here is that globe and guard. And so this is how we get international prices into Medicare and Medicaid. Of course, this is just a proposed rule. There is a lot of back and forth, as I think you know even better than I, about how this is all going to work out in the end. So there's probably a couple of ways, to look at it. One is on the very kind of operational end. What are these programs? How do they work? What countries are we referencing pricing from? How do we get those prices in? And I think there's going to be a lot of back and forth on that because these are incredibly difficult questions. You run into these tricky details almost immediately. So what is a price? How do we deal with confidentiality? How do we deal with the reality that the company that markets a drug in Europe may not be the company that markets a drug in the United States? And actually, if you look at the comments from BIO, the trade organization, they say, well, sometimes there's actually three parties. You've got the small biotech that invented the drug, and then they license the rights in the United States to one company, and they license the rights in Europe to a third company. How do you begin to coordinate between all of those pieces in a way that's going to be, legally kosher? So I think there's a lot of operational questions. And then there's the philosophical question of whether or not the United States really wants to put power to control prices in this country in the hands of European bureaucrats. It's not clear to me, why we think that Belgium should have veto power over what drugs cost in the United States. And I don't mean to pick on the Belgians. It's just, again, the idea of European governments essentially setting U.S. policy strikes me as something that was traditionally ideologically opposed by a lot of policymakers, and now we seem to be in the world in which that's okay. So,
So,
how
Brian,
do
you
we find
follow
it?
this administration very closely, right? I mean, like you
Yeah.
said, every morning, God bless you and your family for getting up and doing all of what you do, right? And you mentioned the 16 deals. We know you and I have discussed that other companies are meeting with CMS on possibly deals, swapping Globe Guard for participating in the generous. Where do you see this going? I feel like the agency is sort of boxing itself into has to finalize the Globe and the Guard rules, and then the game is afoot regarding litigation. And so, what do you like I said, where do you see this going?
I mean, I think you've got it right. There's going to be litigation. Apparently, if you have signed an MFN deal with the White House, you are exempt from Globe and Guard. Globe and Guard only affect, that they're designed as models, so they're only targeted at 25% of the population. They're time limited. There's a lot of reasons to think that this is not going to be the magic bullet that suddenly brings in international reference pricing. So I think this is why there is, much vogue, among administration officials for what can we do to codify this in law. I've used the word codify more in the last 6 weeks than I think I have in my entire life. This idea that can we do something to create some teeth to make this a long-standing thing? And quite frankly, when you start talking about enshrining something in law, people get real nervous. Industry doesn't like it. Suddenly, conservative Republicans, people like me who remember the 80s, remember what kind of conservative political thought stands for, starts getting real nervous about putting the idea that, again, the French or the Belgians or the Spanish are going to, enshrined in U.S. law, have the power to set U.S. prices. So that effort seems to be, on rocky shores a little bit.
Yeah, I agree. I don't think there's an appetite, especially for the remaining time we have in this Congress, for the Congress to pass anything codifying. You're right. I mean, I have used the word codify more than even I think when I was practicing law. I've used codify more the last couple of weeks than
It's terrible. It's
I
terrible.
even when I was practicing law. So yeah, and then I think, like I said, I think we're going to box ourselves into finalizing the rules, and then there'll be litigation. And it's going to be fascinating to me, as you mentioned bios comments. There's Pharma, there's a lot of already preview
Yeah.
of what those legal arguments are going to be, both constitutional and policy oriented. So we'll get to that, but give us a prediction. You got some reading of the tea leaves and how you think this is going to go. I know it's an unfair question. I'm happy to answer it too, but I want to get your thoughts first.
I mean, it's hard to see, again, when you look at all of the exemptions and exceptions and moving pieces and time limited and the prospect of litigation. It's really easy to say, look, these models are not probably important in themselves. I think you're going to end up clarifying a few things, though. One, you may end up with some better idea of what CMS has the authority to do. And B, you're essentially setting a debate that's going to go forward, because one of the more amusing things that's happened so far this year is every once in a while Bernie Sanders will come out and try to slip an amendment that looks very much like Trump's MFN policy into an actual Republican-sponsored help bill. And everyone kind of laughs and votes against it. But I think it's showing that this is not just a Trump thing. And as we look out towards 2028, 2032, does the political wind shift in Washington? It's pretty clear that there's a constituency for for equalizing U.S. and international pricing. And so it's very difficult to see this as a trend that somehow magically goes away, when Trump leaves office, or magically goes away if Republicans lose control of Congress. This is something where it polls great. Again, I think there are technical reasons and philosophical reasons why it's a bad idea, but man, people love it.
Yeah. So my answer is I think we're going to have litigation, and I think it's very tenuous that the government survives the litigation. I think there are constitutional issues regarding appropriations, major issues doctrine, like we saw with the tariffs, and then there's a lot of abuse of authority on the CMMI statute in and of itself here. But I also agree that this issue is not going to go away. It polls well. And because of the way the question's asked, do you want to pay lower prices for your drugs? Of course, right? And
Right.
so, right, it reminds me of the ACA debate where everybody was like, I don't want the government involved in my business and don't touch my Medicare, right? Which is sort of counter intelligent, right? So I agree with that. I'll go first to my question so we can bounce it off a little
Yeah.
bit. And my next question is, what should we be watching for that maybe people aren't watching that will crystallize your point about this MFN debate not going away? And so what I speak about is the PDUFA negotiations, right? We've got a PDUFA negotiation that's coming, needs to be wrapped up September 27, right? October 1, the new fiscal year is a new PDUFA. And most of the agreement is already baked from what I understand. But to your point with this drug pricing European model, but not importing Europeans, qualities and everything else, I say you could see a situation where, especially McCary, if he's still there, right, talks a lot about drug pricing. Do you see a situation where perhaps as a condition of FDA approval, all of a sudden we have a HTA analysis, we have something like that? Is that a sleeper issue, or do you think that's a bridge too far?
I mean, you're the lawyer. That strikes me as being far outstripping the FDA's authority, and that feels like something that would be fun and easy to litigate. Now, you see the administration trying to slip some of that in there. One of the criteria for the commissioner's priority review vouchers is, if you're willing to cut prices, or if you're willing to accept MFN, we will give you some goodies. Of course, there's been questions about whether or not that's kosher as well. So I think that's certainly one way of doing it. I think to as long as we're kind of running counterfactuals here, I think one of the things that may take this train off the tracks a little bit is this idea that if we make it harder to enter international markets by demanding that prices go up internationally, which is of course the flip side of demanding that prices go down in the United States, I really wonder over the next 5 or 10 years if the Chinese don't see that as an opportunity. If U.S. companies can't compete in Europe and the Chinese do, is that essentially the United States giving up access to European markets and allowing, Me Too-ish drugs, from China to go into a vacuum that's essentially created by the MFN policy? And you're beginning to see that crop up in commentary more and more.
Yeah, no, I agree completely. That if I'm a European leader, and I've had these discussions with consultants across the pond, you are now sitting back and saying, I cannot rely on the United States for my drug supply anymore, right? That is gone. I need a safety net. I have a responsibility to my citizens, right? And so what does that mean? Either I compulsory license or I just let China come in and do exactly that. And so I agree. And it's ironic because because the policy will have the exact opposite consequence, which doesn't surprise anybody here that it would have the exact opposite consequence. But so I think so we pretty much agree, right, that there's a lot more to be written here on the
Right.
Globe, the Guard, and the Generous, and more broadly that even if those are defeated in some way, this concept of I'm paying too much for my drug as a political issue is not, however, gone by any stretch. And so, speaking of which, right, an issue that is, I know, a favorite of yours is what do we do about the quote unquote horrible middlemen that our president has talked about on the campaign trail and executive orders, and now we have FTC agreements, we have Department of Labor proposed rules, we have new legislation. You've been following this very closely. Are we at a point where we have a distinction without a difference? Have we actually done anything to the PBM model? Do our listeners need to worry about access to new oncology drugs or old oncology drugs and more prior auth and more this and that? Or will the patient the experience at the patient level will still be the same? So give us a little bit more detail about what has sort of occurred and what your thoughts are and how all these separate swim lanes that I just filled meet at some point at the end of the pool.
Yeah, well, I mean, clearly there's more pressure on the PBM business model. The legislation that passed earlier this year, that adds transparency, that moves towards delinkage of PBM fees and prices. That's all good that's all good. That's all been widely advocated. The Express Scripts settlement with the FTC, and it looks like we may get another one or two here in shortly. I think those two, very much about transparency, bringing those lower prices to patients, getting rid of some of the games being played with rebates. Looks great on paper. DOL, the Department of Labor rule that would really amp up the fiduciary responsibilities of PBM. I think that's all pushing in the right direction. There are reasons to say, yeah, this is good. This is going to bring us to a PBM industry that gets back to what PBMs used to do, which is they're going to play this role to smooth transactions. They're going to play this role to kind of find lowest prices. That's what they ought to be doing. So you can look at all of this and say this really sets the stage for an evolution in the right direction, an evolution towards patient centricity. You can also say, well, great, we have seen the PBMs under pressure repeatedly, really over the last decade, and they have always found a way to shift their business model. They've moved away from rebates, and now they're into fees, now they're into specialty pharmacy. How are they going to adapt to these new pressures? Because they've done this successfully in the past. And if you look at the FTC settlement, if you look at some of these other pressures, honestly, it shifts a lot of the responsibility to holding PBMs accountable to their customers, to employers. If the employers choose to keep buying the old school PBM offering because that's what their brokers tell them to, because it's too complex, because they don't understand what's going on, they're going to be stuck with the old PBM system. And so I think there's a lot of question as to whether or not the system can get smarter faster than the PBMs can kind of try to evade this. And honestly,
so which way does it go, Brian? Which way does it go?
Well, I will tell you, you can start asking independent pharmacists
Okay.
because you started seeing contracts from the PBMs go to independent pharmacies under these kind of new rules that have been created by the FTC and the congressional legislation. And what the independents will tell you is these deals they may look different, but they're not better for them. That at the end of the day, the PBMs are still getting their cut. They're finding ways of making contractual alterations that are going to keep them within the letter of the law, but are not necessarily going to redistribute the money and the dollars and the revenue. I think the question is, how much more of that are we going to see?
So let's look at a little bit of the players here, right? The independent specialty pharmacies, or the independent pharmacies, bricks and mortar, probably net neutral, maybe even a little worse for them because they've got an expense in transitioning to a different contract paradigm. What about, now you mentioned the customer of the PBM, whether it's the health plan or the self-insured. I'll give you my thoughts. I think I agree with you. A lot more transparency. I think some of that transparency is good. Some of it could be bad, right? And what we do with all that information and how that all works, right? We've got a biopharma company that lives on both sides of that fence, seeing how all the rebates are and seeing your competitor's channel. And then what I also don't know is how AI will start integrating all of that information and really start understanding the employee experience and designing formularies and designing networks and what role does the PBM have. So I think it's really too early to tell what that does for the plan and what that does for the self-insured. What are your thoughts about, so I agree with you there, but what are your thoughts about what does it mean for the manufacturer? What does it mean for the innovator and the launch of a new oncology drug? What do you think is going to happen there?
Well, it's interesting. I think what's happening in oncology when it comes to PBMs is probably different from a lot of the legislative bit. I think in oncology, manufacturers have had a long time in which they have been able to price based on the fact that the drugs are an important tool for the clinical community. There has not been a ton of formulary games played with oncology. There has not been a big gross to net bubble to talk about, unlike a lot of other more generalist medicines. And so, but what you are beginning to see is this recognition that maybe those days are over and maybe you're going to see more pressure to contract, more pressure to rebate in oncology. So if you're a manufacturer, I think you're worried that essentially PBMs are increasingly going to stand between your physicians who are prescribing your drugs freely according to patient needs and the PBM's ability to regulate that. And I think that's where that change is starting to come in. And you're beginning to see this in small ways where there are more restrictions, there are more barriers being put on the PBMs on how cancer drugs are used. And I think that's something that's worth watching, and I think how people respond to that, manufacturers, lawmakers. Do we want PBMs to play a larger role in cancer care? And I think if you're a patient, if you're a physician, the answer is probably no. But certainly we're likely to see more of that, because that's largely not affected by any of these kind of larger legal forces acting on the industry.
So what I've seen early on is the following. You've got the PBM business model transitioning, and you've got this requirement, of course, that the rebates all pass through, and this transition into a bona fide service fee that has to be at a dollar value, right? As you mentioned, that occurs through the legislation, the DOL. And what is going to be interesting to see, per your comment, I agree, is that the PBM now has to make up for that percentage-based contract on the services with actually dollar services and come up with more services. And how, A, is that a legitimate service, and B, is it at fair market value? So I'm seeing my manufacturers, I wonder if you are too, sort of coming up with, well, what do we think a PBM should be doing, right? To your point, what services should the PBM be providing to patients, physicians, their customer, and then should we be paying for them? And so that'll be like disease management, or I don't know what they're going to be, but that'll be interesting. What are your thoughts about that?
No, I mean, I think that's absolutely where we're going. I don't know how happy the manufacturers are going to be to pay any of that, because I'm not sure that the PBMs are providing a service that is commensurate with what they're demanding. But they're the gatekeepers, right? I mean, that's the problem. You really are negotiating with a group that has a tremendous amount of leverage. And so I don't know a single manufacturer that's happy about paying these fees. I don't think you have a single manufacturer that thinks that those fees are worth what they're paying. But, what are you going to do? Again, you got three players controlling 80% of the market. You do not have a whole lot of flexibility to play hardball.
Yeah, so I agree. And one of the services I've seen already is try to reintroduce a value-based contract, outcomes-based. So we'll see how all of that goes. You and I have both been around healthcare. We've talked about this long enough, where we sort of say what's old is new again, right? And sort of.
Well, I mean, they're great ideas. They're just really hard to execute, right? Like no one is going to say like, "Hey, I'm against paying for value." But you start saying, "Okay, well, how do you want to pay for value?" It's like, "Well, get out your slider rule,
a rebate. That's how you give me a rebate."
Well, yeah, exactly. That's my call to make. Don't ask me for the math. Just trust me.
That's exactly. Trust and verify, right, Brian?
Right. Oh, geez.
Right. So speaking of the PBM market, here we are, just gone through some rulemaking and some rate setting on the Medicare Advantage market and the freestanding Part D market, which continues to evolve as a result of the implementation of the Inflation Reduction Act, which created a out-of-pocket max for the Part D benefit, which is great for patients, but is creating really interesting financial pressures on the payers, as we would expect, right? And as you mentioned, and we've discussed and is known, healthcare costs continue to rise. So give us a sense of how you think the Medicare Advantage and Part D market is going, and what is the future there? Do you see any future upcoming changes? So give us a couple sentences on your thoughts on the marketplace and what to expect.
You teed this up really well. Prices are going up, and there's only two things that can happen in an environment where prices are going up for the plans. One is you can charge more premiums, or two is you can do your best to control costs in terms of what patients actually receive. There's actually two other things. You can just leave the market entirely, or you can ask the government for help. And we've seen a lot of that. So we're seeing shrinking number of plans. We are seeing continued government, subsidies here. But, at the end of the day, I think everyone has to be prepared to be living in a world in which, you're paying more and getting less for your Part D dollar, and that doesn't make anyone happy.
But
I haven't seen But I haven't seen anyone propose a structural solution for how we're going to get out of that. And the thing is, like, right, part of this is because we have instituted this out-of-pocket cap for patients, and that's obviously a fantastic thing. But the reality is, a lot more of the responsibility now is shifted to manufacturers and mostly plans, and they are acting absolutely as one would expect when they have more financial skin in the game, which is, they're going to raise prices and lower offerings.
Yeah, and ever since the Congress introduced this concept of mandating rebates in 1992 with Medicaid, we as a Congress have been addicted to rebates, 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 which, right, as you just said, they love them, but that also incentivizes higher launch prices, and round we go and more rebates. And I think we're headed towards a significant issue by the end of this decade when you look at the trends for the out-of-pockets, right? So this year it's $615 deductible, $2,100 out-of-pocket. Next year it's $700, $27, $2,400 out-of-pocket. Those numbers are adjusted by drug spend, not CPI or COLA, right? So the Social Security checks are going up at a much lower rate than those out-of-pockets. By the end of the decade, it could be a $3,000 out-of-pocket. And here we are back with a Part D program that's unaffordable. And so it'll be an interesting ride for the next couple of years, and then past that on what happens. So you've got this PBM going on, reform. You've got this Medicare drug rebate being implemented, the drug benefit being implemented, and now you've got negotiations going on. So give us your thoughts about how you think the negotiation program has been working the last 2 years. Do you expect this is the first full year this administration is negotiating drugs? Do you foresee a significant difference in the outcomes for 28 than you saw in 26 and 27? How do you think it's going so far?
It's interesting, right? Because you don't hear a whole lot about this, either way. That it's certainly not creating a huge benefit for patients. This idea that your Eliquis is now available to the payers at a cheaper price. It doesn't necessarily mean that your burden is going to be less. And despite, I think, all of the hype when the IRA was passed and as the negotiations were happening, I have not seen rosy pictures about seniors who are suddenly unshackled from the high price of their of one of these first 10 medicines to be negotiated. I think what will be interesting over time is this program going to take pressure off of the payers in some meaningful way? I think we've pretty much established that it's probably not going to have a dramatic impact on the actual out-of-pocket cost for seniors. That really the $2,000 or, to your point, $2,100, $3,000. Yeah, the out-of-pocket cap is making a difference, but I don't think that anyone is seeing a dramatic benefit in their life from the negotiated prices. And so the question is, are the payers going to see that benefit? And if and when the payers see that benefit, is that then going to get passed back along in some way to the patients? And those are big and important unanswered questions, because if the lower prices for medicine is just a way to kind of take the financial pressure off of payers, but that doesn't trickle down to the rest of the healthcare system, maybe it's a victory for sustainability, but it sure doesn't feel like a victory for affordability.
So last issue for our conversation this morning, which sort of continues the theme of a program that's growing with There's No Control, which is, I know, a favorite of yours. I can see it on your face. You know where I'm going. It's the
I love it.
Right? So
never has there been a program that is more boring yet more important. The ratio of just dullness to critical is just outrageous.
And so yesterday, as you know, AbbVie sued HRSA on the definition of patient, exactly to your point, right? Example number 7,000 about how this is constantly in the news. Do you ever see, it seems to me, I'll start first, right? It seems to me that really where we are, and I think actually you've written about this numerous times, so I'll give you credit for the idea, is the way we're going to get 340B reform is not through Congress, and HRSA doesn't really have the authority to do much from a regulatory point of view, is through the courts.
Yeah.
And that's what we're seeing. So give us your thoughts. I mean, I know like I said, that's your original thought. What else do you think here? What are you expecting next?
I mean, I should ask you as the lawyer, because at this point, almost every piece of this is being litigated. The patient definition is being litigated, and contract pharmacies are being litigated, and Hearst's authority is being litigated. And all of this stuff is, I mean, we're going to have legal answers one way or another. I mean, in fact, we may get, and you legal geeks must love this, we may get, the state contract pharmacy regulations heard before the Supreme Court, which would be
Probably
a big victory for people who care about 340B but can't get other people to care about 340B, because people seem to care about whatever the Supreme Court cares about. But it's just, the points I try to make on this is for people who try their best not to care about 340B. My argument's always that this is an enormous program. It's $80 billion a year at 340B prices. You're looking at hospital, whether you call it profit or additional margin of, 60, 70, $80 billion a year. If you take that out, 20% growth, which is what 340B is growing at, hospitals are going to make an additional $1 trillion in revenue in the next 10 years. There is not a single problem in healthcare that you can't solve with $1 trillion. And so the question that I ask is 340B solving the right problem? Is that $1 trillion over the next 10 years being put in the right place? And the answer may be yes, that it's important to have a safety net for hospitals, and maybe you need to fiddle with the edges, but it's important. But we haven't had a debate about exactly how we do that and whether or not 340B is the right way to get there. So unfortunately, a lot of that is happening in the courts, which is probably not the best way to create public policy. But honestly, do I trust Congress to tackle this?
no way.
Maybe not.
No, I agree with you. I think we are where we are with the courts on 340B. So it'll be a long slug through all of these issues at the courthouse. All right. Thank you for your time. Last question here, right? What issue is percolating that most people aren't really paying attention to that is really an important issue? Now, I'm happy to go first to give you a chance to think about it. It's an obvious answer to me, which is the continued use of artificial intelligence. There was an article recently about how patients are using chatbots to appeal claims, and how physicians are using it to, quote unquote, more accurately code, and costs are going up. And so the prevalence, the tentacles, the depth and the breadth, I think, of the AI. It may be too obvious of an issue. Maybe people are really looking at it. But what are your thoughts about what should the listener be thinking about that is going to be relevant that we haven't either talked about or really you haven't seen a lot in the public headlines on?
Let me kind of riff just a little bit further on something that is related to the 340B point, which is that you are seeing hospitals, clinics, physicians increasingly profiting off of things that are not patient care. I think the most clear evidence of this is pharmacy. If you look at any big hospital system, they have seen over the last 5 years, doubling, tripling, quadrupling of their revenue from pharmacy, because that's where the money is. And my question becomes, what becomes of our healthcare system? What becomes of our drug supply channel when essentially the providers and other people who are not kind of traditionally, seen as the key drivers here suddenly find a way to profit off of drug prices or spreads or things like that? We've had a 10-year experiment on what happens when PBMs have figured out how to tap into that revenue stream. Increasingly, I think we're seeing hospitals and clinics come to the same discovery. And, ultimately, what's that going to do to the system, and how is that going to warp things in ways that we may not fully anticipate?
Well, I think what we've sort of concluded here is that there's a lot more news, right? There's going to be a lot more change. There'll be a lot of headline risk and real risk, which is why I think everybody who's listening to this podcast should subscribe to your cost curve.
Absolutely. It's because we're going to have this fixed in the next 18 months, but I feel like in the next 18 months, you should totally be reading.
Yes, very much so. So that wraps up our episode of Value-Based Voices. Thank you all for listening. Thank you very much, Brian, for sharing your insights and for joining me in this conversation.
Thanks a lot. It's been a blast.
If you found today's discussion thought-provoking, be sure to subscribe, to both Brian's website, his distribution list, and to Value-Based Voices, wherever you get your podcasts. Stay tuned for more episodes that spotlight the voices shaping the future of oncology.